Good evening. Thanks to each and every one of you for being here with us today. I, Ankit Dogra, along with my teammates, Dr. Deepika Chhabra and Ms. Ramit Saxena from Medical Services, Jagsonpal Pharmaceuticals Ltd, are very pleased to welcome you all to today's webinar on cervical cancer screening and colposcopy updates organized by the Society of Meaningful Life Management in association with Indian Menopause Society, Delhi chapter, with academic partner Jagsonpal Pharmaceuticals Ltd, makers of LycoRed, the oncopreventive cell protector, soft gels of lycopene, zinc, and selenium. We also present Doxypal DRL capsules of doxycycline and EndoReg 2 mg tablets of Dienogest for the management of endometriosis and endometriosis-associated pelvic pain. Dear attendees, if you have any suggestions, questions, or clarifications, please post them in the Q&A box. Please note this webinar is streaming live on the Facebook. The link is shared in the chat box. Also note, for the future reference, we'll upload this webinar on our YouTube channel, Jagsonpal Medical Insights. Now, let us welcome the Master of Ceremonies, Dr. Gurpreet Kaur, to kindly take the proceedings further. Dr. Gurpreet Kaur is the Secretary, Raipur Menopause Society. Dr. Gurpreet Kaur, please.
Good evening, everyone. Today, we all are here together for a noble cause to learn about screening of cancer cervix and its importance, and also to learn the process of and methods of screening of cancer cervix. As we all know, cancer cervix is one of the major causes of morbidity and mortality in midlife and elderly age groups in India. Although we have so many screening techniques, still we are missing on some precancerous lesions, and still we are seeing the cases of cancer cervix in our daily OPDs. So let's join our hands together and learn to screen our gynec patients. And as we all know, prevention is better than cure, and so is screening is better than treatment. So let's learn the screening techniques and learn the screening techniques and to know about HPV DNA testing and colposcopy through the stalwarts. On behalf of Society of Meaningful Life Management and IMS Delhi, I would like to welcome our chief guest, Dr. Ambuja ma'am, and guest of honor, Dr. Minakshi Ahuja ma'am. And also I would like to welcome our golden girl of Indian Menopause Society, Dr. Maninder Ahuja ma'am, who is convener of this program. I'll take the pleasure to welcome our speakers, Dr. Minakshi Ahuja ma'am, Dr. Ruchika Garg ma'am, Dr. Maninder ma'am, and chairpersons of these programs, Dr. Sonal Gupta ma'am, Dr. Indu Taneja ma'am, Dr. Anita Sabharwal ma'am, and very warm welcome to all our delegates and chairpersons. So now I would like to invite Dr. Maninder Ahuja ma'am, who is director of Ahuja Healthcare Dental and Infertility Center. She has dedicated 40 years for women's health from adolescence to menopause. She was in charge of CEPHOMS 2010 to 2014, Secretary General 2014 to 2018 CEPHOMS, Vice President since 2018 CEPHOMS, Vice President FOPSI 2013-14, President Indian Menopause Society 2014-15. She has affiliations with many professional bodies like ISAR, ISPAT, NARCHIEF. She is author and editor of many publications and author and editor of book on early diagnosis and management of pre-malignant lesions. Dr. Maninder Ahuja ma'am, I welcome you to invite Dr. Ambuja ma'am and Dr. Minakshi Ahuja ma'am. Thank you, ma'am.
Thank you, Dr. Gurpreet, our young brigade, who is going to carry our torch forward among all the organizations. But wherever I go, I give them opportunity, because these are the younger people who will be really being effective in working for the women of health of tomorrow. So we are doing these series under Gyan Vardhak series of SMLM. We are normally Society of Meaningful Life Management was formed with the idea of going digital, but COVID-19 made us go digital. So that's very easy for us to work on this in these platforms. And the purpose is to carry the work forward wherever we feel it's being neglected or needs more care. So making the things meaningful and effective. That is our purpose. So why, if we are lacking some field, we want to know why we are lacking. So keeping that in mind, we had our webinar series on anemia from womb to tomb. So why we are having is starting from our pregnant mothers itself. So why we are anemic, then go to the adolescent age and everything. Then why there is a gap between healthcare providers and public and media and everything. So what is the financial health of healthcare system? What do we need forward messages? We have been doing webinar on those issues. Then never discussed issues of undiagnosed genital problems at birth of the babies. Then issues of why there is a gap between our perceptions and effectiveness of the procedures, why the government of India does not listen to us. So we made a collaborative group with the SAR, IFS, IMS, fetal medicine, all these groups. And when there was COVID times, we made a joint statement why the COVID vaccine should be given to pregnant women also. And we came on the media also, and along with the efforts of our associations, other associations and collaborative group, the pressure on the government was there, and we were able to have that vaccination proposed for the pregnant women also. So same way, there are so many issues where we can work together. Now, cervical cancer screening is one of the issues where we have been working for so many years, like anemia, but still mortality is not coming down. So I thought, let's go again and discuss these issues along with Indian Menopause Society. And Dr. Ambuja is such a great person. She always comes forward to help and give her positive thought processes. So it's very honorable for me to introduce Dr. Ambuja here as our chief guest. Dr. Ambuja, CV, please. I can introduce her without looking at CV also, because she's such a gentle, dynamic and thorough personality. As president of the Indian Menopause Society, as she was just talking, we are doing the online elections and she is taking it so seriously and seeing to it that each and every person of the Indian Menopause Society is able to vote for that. She is the research committee chairperson of SEFORMS also now from 2021 to 23. And we are already starting a project now under SEFORMS and IMS and everything, relationship of menopause to metabolic syndrome. She is retired professor and HOD of Institute of Obstetrics and Gynecology, Osmania Medical College, Hyderabad, and visiting professor, Sweta University, Chennai from 2019 onwards. She is All India Vice President of Family Planning Association of India and faculty and resource person for National Board of Examinations from 2001 onwards till date. And she is treasurer of Society of Obstetrics Medicine India, SOMI, and peer reviewer of JOGI, JMH, MRIS Journals of Health Sciences, and consultant editor in JK Science Journal of Medical Education Research. And she's undergraduate and postgraduate examiner also. So Professor Ambuja Choranur, it's an honor to welcome you here, and we would like to have a few words from you.
Thank you very much, Maninder, for your kind words. I'm really, really honored to be here as the chief guest because I love you all. That's the first thing that makes me to come and be 50 minutes ahead of your time. Thank you all for inviting me. My dear Mala Srivatsa, my dear Maninder, you are great, and what can I say? You are like a role model to all the youngsters in every way. Dr. Gurpreet Kaur, Secretary, Raipur Menopause Society. Dr. Minakshi Ahuja, President, Indian Menopause Society, Delhi chapter. I'll tell you, Minakshi, you are very really resource person, great. In spite of your so many activities, you are participating in the TV shows, this and that, but still you have taken IMS as such a prestigious, and you are organizing so many programs. Dr. Sonal Gupta, Secretary Faridabad Menopause Society, and Dr. Ruchika Garg, Secretary Agra Menopause Society, Dr. Indu Taneja, Vice President Faridabad Menopause Society, and Dr. Anita Sabarwal, Chairperson Public Awareness Committee, ISCCP. Good evening to all of you. And it is a great day that you are having such a wonderful program. Along with the SMLM Society, that is the Society for Meaningful Life Management, and Delhi Menopause Society chapter. And it is great that Deepika Chhabra, she is coming forward to organize so many programs. I know Deepika since about more than 12 to 13 years and work very closely with her, travel together, and I know her what it is. She's a silent listener, and I can say she's a silent worker. More than anything, she does work so perfectly and wonderfully. Thank you, Deepika, for all the support you are giving to Indian Menopause Society for years to come. So nice of you. And I'd like to appreciate you people for taking up such an important topic. And I really welcome all the eminent speakers that are here. But only one question that lurks in my mind is, in spite of repeatedly we are talking about the cancer cervix prevention and whatnot, so many things we are doing, but still India is the first in the incidence of cancer cervix in whole of the world. Why it is happening? Where we are lacking in communicating the same thing to the public, because the final end result is what? India should be in cancer-free society, that should be there. When you go into the details of certain of the facts, what happened? No? The high incidence of cancer cervix in India is a big challenge. We have two more important challenges. One is primary prevention, and because of the late detection, that is, whatever we do, still we are getting in late stages, sometimes in the fistula stage, and after the age of 70 years. Why it is happening? Because we are not detecting them properly. Where do we fall wrong? That also we don't know. Day in, out, we see that so many people will go for the health camp, so many people will conduct this and that, but still the things are not met. And cervical cancer profile in India is crude cervical cancer incidence per 1 lakh women is 18. And cumulative risk of cervical cancer between the age of 0 to 74 is 2%. Cervical cancer deaths in 2019 reported is 45,300. Fewer than 110 women have been screened for cervical cancer in the last 5 years. Mind it, it is such a heartening to think that less than 10% also we are not able to screen. Government of India introduced strategies in various 5-year plans for early detection. 2013, finally, there was an integrated approach by the Government of India, where the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke, but none has worked out satisfactorily until now. In 2016, the Minister of Health and Family Welfare in India recommended cervical cancer screening using visual inspection with acetic acid every 5 years for women aged 30 to 65 years. It is still going on. The results will come out only after five years, not now immediately. Unless WHO strategies are met, we cannot eliminate cancer cervix. What is the WHO target by 2030 is 90% of the girls fully vaccinated with the HPV vaccine by the age of 15 years. I think Australia is the only country which has met this target until now. And 70% of women are screened with the high performance test by 35 years of age and again by 45 years of age. Forget about high performance. We are not able to do a simple Pap smear test for everybody. 90% of women identified with cervical disease receive treatment. Of course, this is happening, but not to the full extent. To discuss about all these things, we have eminent speakers, and I feel we will be benefited out of it. Thank you again to Maninder and Minakshi and all people who are involved for choosing such an important topic. More than that, for inviting me as a chief guest. Thank you very much.
Thank you, Ambuja, for those pearls of wisdom. And I always know you always give something positive inputs wherever you are invited. And at the same time, I must thank, as you have done, Jagsonpal to start with only. So Deepika is our right hand, left hand. For me, sometimes she's both hands. And she is such a gentle person. And I don't know whether being a doctor or whatever it is, she has been associated with Indian Menopause Society from the very beginning, and she got our 2 research projects done. One was the LycoRed. Second was the age of menopause and determinants of age of menopause. She helped me in that also, and she is ready to help me in my 3rd project also. So she
LycoRed, I cannot forget. We went round everywhere like Bhopal, Chandigarh, so many places, and we gave lectures about the LycoRed. I cannot forget about LycoRed.
So LycoRed clinical trial that we had done for bone health.
That's another
regularly. I am taking regularly LycoRed because it's a very good antioxidant we need also in this age group also. Now I'd like to introduce our guest of honor,
Mala Srivastava.
Please show me a CV. She is a senior consultant and professor, Gynae Endoscopic and Robotic Surgeon, Gangaram Institute. Now it has become the research institute also, and Vice President-elect ISOPAR 2023 to 23, past President AOGD 2030 to 20 to 21. And her area of interest are, of course, gynae oncology, gynae endoscopic surgery. She's a fellow of minimal access surgery. And she's a body of many, many awards, excellence awards. And being such an academician, she's such a humble and down-to-earth person. And she's now coming for the, Dr. Mala, you have not mentioned here. Which committee?
Adolescent Health Committee.
She is coming for the Adolescent Health Committee of FOGSI, and we should all support her, because wherever she is going to be very active and very effective. And Dr. Mala, please to you for your few words of wisdom on the cervical cancer.
Thanks, madam, for your very nice and kind words. Good evening, everyone. It's my privilege and pleasure to be a part of this e-learning on cervical cancer screening and colposcopic update. Dr. Maninder, ma'am, she is the president of Society of Meaningful Life Management, is a great personality and iconic personality. We all benefit from her iconic personality, excellent academic endeavors. Cervical cancer is the 4th common cancer in the world, but in India, it is 2nd most common cancer. Cervical cancer has a long pre-invasive stage. We should be able to pick it up easily by simple tests, by per-speculum examination, by Pap smear, LBC, HPV, via villi. All these are screening methods. But incidentally, still, we have new almost 1,22,000 new cases of cervical cancer occurring in India, and almost 77,000 deaths occurring per year in India. That's the state of affairs in India about cervical cancer. We must talk about primary prevention, secondary prevention, and tertiary care. Primary prevention is by vaccination. We have cervical cancer vaccination against HPV DNA for so many years, but still we are lagging behind in awareness, and our general population is yet to understand the importance of cervical cancer vaccination. Secondary prevention is by screening. Screening by via in the low resource setting should start at the age of 30 years, and it is done every 5 years. And every woman, if they are screened by via, should have at least 3 such screening procedures throughout their life. If by screen by conventional Pap smear or LBC, then every 3 years by cytological screening should be done. But if we are doing by HPV DNA primary screening, then every 5 years the screening should be done. And the screening should start at the age of 30 and it should stop at the age of 65. This is in a nutshell about cervical cancer screening. And of course, when we find any abnormality on the screening, we have to supplement it by colposcopy and cervical biopsy. Dr. Ambuja, you are a great personality. You're the president of IMS, and we know during your guidance, IMS will achieve great heights, and you have a good academic endeavors, and you're going to really enrich the society of IMS with all your experience and expertise. We have Dr. Minakshi Ahuja, who is the president of IMS Delhi chapter.
Thank you, Mala. Thank you very much.
Yeah, we know you for so many years and we're really working hard for the IMS society. Dr. Minakshi, you are really working greatly as a president of IMS, as Dr. Ambuja rightly pointed out. You are doing real hard work for the society of IMS for Delhi. Dr. Ruchika Garg, who is the secretary of IMS Agra chapter, you are going to enlighten us of HPV DNA as a primary testing. Madam Dr. Ahuja, she is going to throw lights on the colposcopy from normal to abnormal. Today evening, we have galaxy of chairpersons who are expert in their own fields. Dr. Sonal Gupta, Dr. Indu Taneja, Dr. Anita Sabharwal. We are going to have very fruitful learning evening today. And of course, Dr. Gurpreet Kaur, who is going to hold the thread throughout the evening and organize this e-learning in a very systematic and organized way. I'm sure everyone, all the delegates will highly benefit from today's scientific deliberations. And as WHO says, we can get rid of cervical cancer by 2030 by the formula of 90-70-90. 90% vaccination for the girls up of 15 years of age, 70% screening, and 90% treatment. And we are also looking forward for cervical cancer Mukt Bharat, which is the slogan of FOXY. I again thank Madam Dr. Maninder Ahuja for having me here, and I wish all the best for today's scientific program. Over to you, Madam, to carry on the scientific deliberations of the evening.
Thank you, Dr. Mala Srivastava, for those words of wisdom. 90-70-90. I think that is going to be the magic figure for all of us to make the Cancer Mukt Bharat. So now I'll hand over to Gurpreet to honor and introduce our chairpersons, Dr. Anita Sabharwal, who is a close friend, and Dr. Sonal Gupta and Indu Taneja, who are my own family, my members from my Faridabad society only, and they have been with me for years together. The way whatever I have work to do, my first support comes from my own society only. And I just don't have words to appreciate Minakshi Ahuja, whom I met. I didn't know that she will be such a vibrant and active personality. every day I find on Facebook and WhatsApp group one other angle of her personality unfolding. And Dr. Ruchika Garg, she is an academician who is with me in helping me in most of my writing projects for my research work also. We are doing here and there some papers like we did in COVID times also. And she is in the associate journals of CEPHOMS and CEPHOG also. So associate editor there. So welcome to all of you. Gurpreet, I hand over to you now for the smooth running of the evening program.
Yeah, thank you, Maninder ma'am. Thank you so much. Thank you for giving me this opportunity, ma'am. Our first topic is screening of cancer cervix. That will be given by Dr. Minakshi Ahuja ma'am. And chairperson for this talk is Dr. Sonal Gupta ma'am, who is consultant and director, NIMS Hospital and Palwal Hospital. She is Joint Secretary, Faridabad Obstetrics and Gynec Society, Secretary, Faridabad Menopause Society. She is an endoscopic surgeon and she has special interest in high-risk pregnancies and gynec surgeries. I welcome Dr. Sonal Gupta ma'am to invite Dr. Minakshi Ahuja ma'am for her talk. Welcome, Minakshi ma'am.
Thank you. Thank you so much, Dr. Gurpreet. It's my proud privilege today to welcome and introduce Dr. Minakshi Ahuja. First of all, I would like to compliment her for her vibrant smile. She is Director, Fortis LAFM, Delhi, Obstetrician Gynecologist and Cosmetic Gynecologist par excellence, President, Indian Menopausal Society, Delhi. She is Academic Secretary, Delhi Gynae Forum, Member, Executive Committee, AOGD, past President, DGFS, speaker at many Foxy and many other public forums. She is passionate about women's health and disease prevention, member multidisciplinary committee AOGD, member quality improvement committee AOGD, and member of reproductive endocrinology Foxy. I welcome Dr. Minakshi. Kindly take over for your next topic.
Thank you so much, Dr. Sonal. And thank you, Dr. Maninder, for having me here. I don't think we could have had a more appropriate time to discuss this topic, because at the end of the day, we all know that January is the month for awareness of cervical cancer prevention. And this is a time when we are going to talk about it, because prevention comes with the vaccination as well as screening. This is a topic very close to my heart. And honestly, I must confess that I'm one of the highest single users of the vaccination. And I'm very excited to be talking about this. I'm not going to, in this topic, talk about how to do a Pap smear or how to do a visual inspection of the cervix, but basically just run over few as an introduction. I think Dr. Mala has already set the stage when she has talked about the magnitude of the problem. But today, I will just be putting in some slides for us to understand that what are the various screening techniques available and what is it that we should be using today. So before I start, I think the most important thing that we've all learned in the last 30 years, that cervical cancer is in more than 95% cases because of the HPV virus. At the same time, we must understand that the HPV virus carries about 660 million cases worldwide. It is not only responsible for cervical cancer, but also high-grade dysplasia, as in 10 million cases, cervical cancer in over 6 lakh women, vulvovaginal cancers in more than 60,000 women, and anal cancers in more than 50,000 men and women. The low-risk types are also attributing to low-grade dysplasias, genital warts, and HPV infections, therefore, carry a lot of significance when we are going to be discussing this topic. So these are the impacts of the HPV, not only cervical cancer, but CINs, vaginal cancers and vaginal intraepithelial neoplasias, vulval cancers, vulval intraepithelial neoplasias, anal intraepithelial neoplasias leading to anal cancer, oropharyngeal cancers, and also other head and neck cancers and genital warts. Talking about the magnitude of the problem and why it is so important to keep on discussing this so that we can take active steps, is that India contributes to 1/5 of global cervical cancer burden. These are the Globocan 2020 figures, in which the calculated value was that cervical cancer cases in the world were over 6 lakhs globally, out of which 1.2 lakhs were from India, which is a figure of 20% plus. Cervical cancer is the most commonly encountered genital malignancy in women in India. It's the second most commonly diagnosed malignancy in women after breast cancer, and the third most common cause of death after lung and breast cancer. Current data from Globocan 2018 also indicates that cervical cancer ranks fourth in incidence as well as mortality among female cancers in the world. India accounts for around 20% of the world burden of disease. And sadly enough, almost 50% of these women, we are finding that they will succumb to the disease. Also here, I would like to make a note that the precancerous cervical lesions are very common in India. The prevalence rate of CIN 1, 2, and 3 is 2.3, 0.5, and 0.4% respectively. What this means is almost 3.5% women are currently having a precancerous cervical lesion. Now, worldwide, the incidence of cervical cancer is definitely going down compared to earlier. Of course, we've had developed countries like Australia where they've almost managed to eradicate cervical cancer. The numbers are definitely going down through many years. And we all understand that the decline in cervical cancer incidence in developed countries was a result of organized screening programs based on the Pap Smear screening. So the Pap Smear screening was first described by Dr. George Papanicolaou in 1928 as cervicovaginal smears, and by the 1940s, it was being utilized as a screening test for cervical cancer. However, it was the implementation of national call and recall programs for 3 early screenings that produced the maximum impact on reduction of cervical cancer incidence. So what we need to understand here is that it is not a single Pap smear which is important. Like, you can't do one Pap smear in a woman and she says, yes, I've got one Pap smear done once, that it's going to help. It is a test which is not very sensitive. And that is why repeated Pap smears need to be done. So this has had an impact on the reduction of cervical cancer incidence and mortality by about 70%. While increasing the incidence of in situ pre-invasive lesions. What this means is that we have been able to pick them up earlier when they were in situ pre-invasive lesions. So the numbers more because we are screening regularly. The success of the Pap testing for cervical cancer screening, despite poor sensitivity, was based on the long precancerous phase of cervical cancer of nearly 10 to 15 years, during which lesions could be detected by repeated rounds of screening. So putting Pap smear in a correct perspective, it is a simple procedure to obtain and maintain specimens, which has a high specificity. But unfortunately, to read the Pap smear, considerable infrastructure is required and it has low sensitivity. So repeated rounds of testing are required. Liquid-based cytology was introduced in 1990 to reduce the drawbacks of conventional cytology, but it had not shown any significant difference in sensitivity or specificity. The advantage, however, was the rate of unsatisfactory smear is reduced. Also, the same sample can be used for HPV, reflex testing, and co-testing. It also has the advantage that other microorganisms, such as vaginal trichomonas, vaginal candidiasis, bacterial vaginosis, chlamydia, and gonorrhea can be picked up on the LBC. Now, coming to the visual inspection with the acetic acid. This has been a game changer because the discovery that visual inspection with acetic acid could be done with a similar sensitivity as the Pap smear led to a change in perspective in developing countries. The WHO guidelines 2013 say that if a cytology-based screening program is in place in any country, it may continue, provided the program meets the quality indicators, including training, coverage, and follow-up. If finances permit, adding HPV tests to it may be considered. But if the quality assurance criteria are not met, the need to change to another test should be reviewed. That is like an HPV test if financially viable, or a VIA. These are the FOXI resource-based good clinical practice guidelines of 2018. They say that we should be doing a cytological screening every 3 years, that's the Pap smear, from age 25 to 65 years in a high resource setting. At the present time, HPV DNA testing has the highest sensitivity. It can be additionally used with Pap smears as co-testing for optimizing diagnosis of high-grade cervical intraepithelial neoplasia. So what is the role of HPV DNA testing? Like I said, used with Pap smears as a co-testing for optimizing diagnosis of high-grade cervical intraepithelial neoplasia. So what happens is that in a situation, if the Pap smear is abnormal, like ascus, but the HPV test is negative, it will reassure the patient that she does not have a significant abnormality. On the other hand, a positive HPV test, she can be immediately referred for colposcopy and managed accordingly. Coming to the role of VIA in cervical cancer screening. It is a simple test which involves application of freshly prepared 5% acetic acid and observation of acetobite areas in 1 minute. Several large studies in India and Africa, led by Dr. R. Sankaranarayan and Professor Lynette Denny, demonstrated the comparable sensitivity of VIA with cytology. It offers the distinct advantage over cytology that it can be performed by trained paramedical staff and gives an immediate result, which allows treatment in a single visit, which becomes very significant in our low resource setting, where women will not keep on coming over and over to the clinics in the villages or small towns. VIA has been accepted as a method of screening for limited and basic resource countries by both WHO and the American Society for Clinical Oncology. WHO has advocated that VIA permits a single visit approach, providing low and middle income countries immediate test results and the screen and treat approach. Studies have shown that in developing countries, screening women once in their lifetime using VIA at 35 years of age, the lifetime risk of cancer can be reduced by 25 to 36%. With 2 rounds of screening, one at 35 years and one at 40 years, further reduction of the relative risk by 40% is documented. FOXI also proposes VIA as the method of screening for low resource settings for the age group 30 to 65 years. So what are the limitations of VIA? It's not as wonderful as we think because it is not an ideal screening method for postmenopausal women, where the squamo-columnar junction recedes into the endocervical canal and it is not visible. So the brush obviously is going to take the biopsy, the specimen from inside, but just on visual inspection, we may miss the squamo-columnar junction, which is where most cervical disease will start. Also, it is a subjective method, and there can be inter-observer variation in the detection of abnormal areas. Although for that purpose, the International Agency for Research on Cancer has described the criteria for VIA positive, and continuous monitoring and retraining is essential for quality assurance. So we now look at the single visit approach, which is now recommended all over the world. It is a see and treat approach in colposcopic clinics at the highest resource setting. Here, the patients are referred with an abnormal cytology report. If the colposcopy scoring indicates a high-grade lesion, a simultaneous treatment is done, either an excision or an ablation. There's a low probability of overtreatment because of the high specificity of cytology. We had discussed that is the benefit of cytology, that it has a very high specificity. A post hoc analysis of the biopsy report or the excision specimen can be done. Now, in a low research setting, we are not looking at a see and treat, we are looking at a screen and treat. So that is also a single visit approach, which is there in public health programs, where visual inspection with acetic acid detects an abnormal lesion, and the criteria for ablation, if fulfilled, we can treat immediately with or without biopsy. There's a lower probability of overtreatment in high prevalence areas. And of course, if a biopsy is taken, a post-op analysis is possible. So the recommendations for screening in a high resource setting include HPV testing, which could be a primary HPV testing or a co-testing with HPV or cytology. Cytology, that is the Pap smear, colposcopy and biopsy, and or a VIA. The target age group for screening is 25 years to 65 years. The age to start screening for cytology is 25, and for primary HPV testing or co-testing is at 30. How often do we need to test? Frequency for primary HPV testing or co-testing is every 5 years, and cytology is every 3 years. In a limited resource setting, we look at VIA or colposcopy and biopsy. The target age group would be 30 to 65, noting that in postmenopausal women, screening with VIA may not be as effective. The age to start, VIA at 30, frequency every 5 years, and at least 1 to 3 times in a lifetime. These are the new American Cancer Society guidelines for cervical screening. Why I'm sharing them is because they are the latest guidelines of 2020. All over the world, they are, it's pertinent that between age 21 to 24, no screening is required. Between 25 and 39, HPV test every 5 years is the preferred technique, and HPV PAP co-test every 3 years is acceptable, and a PAP test every 3 years is acceptable. Between 30 and 65, again, the guidelines remain the same. HPV test every 5 years is the preferred technique. HPV PAP co-test every 3 years is acceptable, and a PAP test every 3 years is acceptable. More than 65 years, no screening is required if a series of prior tests were normal. So if these screening tests save lives, isn't it better for people to get tested more often and with more tests? No, not really, because the changes are very slow. Doing Pap tests every 6 months, every 3 months, or every 9 months or 12 months also is not helping us save more lives. If anything, it is making women more anxious about their Pap smear testing. And at the outset, we must understand that it is a slightly uncomfortable test. So increasing the discomfort and anxiety doesn't make sense. Screening more people makes more sense rather than screening a woman every 3 months or 6 months, because the changes are very slow. And that is why, if everything is okay, the screening is recommended only every 3 years. Do people who got the HPV vaccine still need to get cervical cancer screening? Absolutely. These are two things which are used in the armamentarium of prevention of cervical cancer. Women need to get the cervical cancer screening done exactly like women who have had the HPV vaccine, exactly like the women who have not had the vaccine. This does not change. And at the same time, I would like to make a point that a woman can get her HPV vaccine anytime from 9 to 45 years of age, as per WHO and FOXI guidelines, whether she has had a Pap smear or not. So the cervical cancer screening and the HPV vaccine, though going hand in hand, are completely independent of each other, and either can be done when the patient comes to you, or in fact, both should be done. So why do the guidelines for cervical cancer screening keep changing? That's the other question which comes in our mind. There was a time where we used to think that Pap smear needs to be done every year. Then we thought it needs to be done every 5 years. Then now we have VIA. Then we had the HPV testing. Then we have the LBC. So exactly why are these changing? So again, you remember that, like I said, the HPV was discovered only 30, 35 years back. And from that time, we are all learning that what is the best cost-effective ratio and why we don't need to waste national money or manpower. And that is why the guidelines are completely fluid. And it's a learning process for all of us all over the world. And that is why we must keep ourselves updated on what is the latest guideline. So what happens after someone gets an abnormal cervical screening test? I think that's what the next two speakers are going to tell us, that when is colposcopy required? What do we do? What about the biopsy? And then how do we further go ahead treating our patients with just an abnormal cervical screening test, which may not be cervical cancer? So today, my part was just to tell you that there are two mainstays of preventing cervical cancer. One is screening and the second is vaccination. And both need to go hand in hand. The color I've used for this slide is teal, because teal is the color for cervical cancer prevention, like we talk about pink for breast cancer prevention. This is my last slide. Together, I believe that we can beat cervical cancer. Thank you so much.
Dr. Sonal.
Thank you so much, Minakshi ma'am. It was wonderful talk. Dr. Sonal ma'am, you want to add something?
Thank you, Dr. Minakshi. It was really wonderful. You elaborated everything in very crisp way, very nicely presented. Thank you so much.
Thank you.
Thank you, Minakshi. I think the one thing which you have brought out is the only constant thing is change. And change is for the better care of the women of this country, and making the treatments whichever are available cost effective is one very, very important issue. And other is that we are always learning new things. Our life is a continuous process and the things are going changing, and nothing like COVID-19 has taught us also that we cannot take things for granted. So we have to learn. That is because this is not the end of learning for us. Each and every procedure we are doing, we are changing after a few years because we are learning new things. So that is where we will be going ahead with the next speaker also. Gurpreet, to you for the next speaker. Thank you. Minakshi will be taking question answers because I found there are some questions in the chat box later on at the end of the session. Okay.
Thank you, Minakshi ma'am. Thank you, Maninder ma'am. For the next talk, I would like to invite Dr. Ruchika Garg ma'am. Chairperson for this talk is Dr. Indu Taneja ma'am. Topic is HPV DNA as primary testing. Dr. Indu Taneja ma'am is Director and HOD Fortis Escort Hospital, Faridabad. She is a DNB teacher, Vice President, Faridabad Obstetrics Gynecology Society, Executive members of various societies, and she has many publications in national and international journals. Indu ma'am, I welcome you to invite Dr. Ruchika Garg ma'am for her next talk.
Yeah, thank you, Dr. Gurpreet, for such a wonderful evening. It's a real treat to have this session today. So this is my privilege to introduce Dr. Ruchika Garg. She is an associate. Just a minute, I'm just actually talking to my phone, still was in hospital. She's a professor in Department of Obstetrics and Gynecology, SM Medical College, Agra. She's Associate Editor's Journal, South Asian Federation of Obstetrics and Gynecology since 2013. Editorial Board Member, Journal of Midlife Health. Joint Editor, Journal of South Asian Federation of Obstetrics and Gynecology, Menopausal Society since 2013. She has many awards to her. She won a Korean Award Senior category for the best research.
Okay, thank you, ma'am, for your kind words.
Yeah, SAR Star Award, Hyderabad 2020.
Okay, let us proceed with the talk, ma'am.
Yeah, now I would. She has actually so many publications and so many awards to her credit that it's really taking time. So I would invite Dr. Ruchika, please start with your topic.
At the outset, I would like to thank Dr. Maninder Ahuja madam for having me on this platform. And I am also thankful to Ambuja madam and Dr. Minakshi. They have reduced my work to 50% because many things have been discussed. And Dr. Mala madam also has brought very important points. So today we are here to discuss about whether HPV can be done as a primary testing and what are the pros and cons of it. So This is the scenario of cervical cancer screening in India. That is only 2.2% women in the urban region and 1.7% in the rural region. The same is with our UP. So, so many women are eligible for cervical cancer screening, but only 2%. Just see this thing, 90, 70, 90 we'll never forget. And we can reduce the incidence of cervical cancer by only screening. So we were doing cytology. So what were the limitations of cytology that we are now thinking of moving to HPV as a primary screening modality? Because in case of Pap smear, in 8% of the specimens, there might be the possibility of inadequate sample. Pap smear has a false negative rate of 20 to 30%. The false negativity might be because of the clumping of cells when the cells are not spread evenly and uniformly on the microscope slide, or they may be contamination with other cells, other things like blood and bacteria. So detection of abnormal cells is not possible. If the slide is exposed to air too long before being fixed, cervical cells can become distorted. And an average Pap smear slide contains about 3 lakh cells that must be examined. And if the sample contains only a few abnormal cells, and then within a crowded background of healthy cells, the abnormal cells can be missed, particularly in government setup where there is too much workload. And it has been found that even after several years of cytology screening, the incidence of cervical cancer has not reduced. As Mala ma'am has already told that 20% of the world incidence of cervical cancer is from India, and very high mortality we have from India. So we know that HPV is responsible for more than 90% of the cases of cervical cancer, and most of these HPV infections are transient and they clear within 2 years of age. So, but if there's a positive HPV test in a woman above 30 years, it indicates a clinically valid persistent infection. Now let us see what is the average sensitivity and specificity of VIA. It is just 55% sensitive and specificity is also only 80 to 85%. Likewise for Pap smear, it is sensitivity is only 58%, but it is quite specific to the extent of 93%. Whereas HPV testing, it is highly sensitive and highly specific. If HPV is there, that means she is having high-grade CIN 2-3. That is, it is 96% cases it's sensitive and specificity is also 90 to 95%. Moreover, it is having a very high negative predictive value. That means if there is no HPV is detected, then the patient is almost free from cervical cancer. It is almost to the extent of 99% negative predictive value. This is another study. Here also they found some different extent of sensitivity and specificity, but here also the HPV has a maximum sensitivity. Regarding specificity, cytology is also quite specific. So now, according to the latest American Cancer Society guidelines, as discussed with our Minakshi madam also, and WHO in 2021, they have declared that in low resource settings, HPV test should be adopted as the primary screening modality. So why HPV? Because when HPV is negative, if there was a study of 12-year follow-up women, a 12-year follow-up, when HPV was negative, only 3.6% women developed cervical cancer after 12 years. Whereas with cytology, those who had cytology negative after 12 years, 13.4% women had developed cervical cancer. And if the VIA was negative, about 1/4 of the women developed cervical cancer. So likewise, there was another study published in Lancet Oncology in 2010. They concluded that they studied 47,000 women were randomized to Pap smear and same amount were randomized to HPV testing. And in the cytology group, 18 women developed cervical cancer in a longer follow-up, whereas 7 women in the HPV group developed cervical cancer. And so they concluded that HPV is more effective than Pap smear in preventing cervical cancer by detecting persistent high-grade lesions earlier and providing a longer risk. HPV test, agar negative aa gaya, to it's a peace of mind that for 5 to 10 years, you are not at risk. Likewise, in another study, this was a population-based study on European women, on 176,000 women. And after a follow-up of 6.5 years, cervical cancer was significantly detected lower in the HPV arm versus the Pap smear arm. So this is the reason that most of the countries have adopted, most of the European countries, Belgium, Netherlands, Turkey, they have adopted primary HPV screening as the primary modality of screening for cervical cancer. Australia, and though Germany has adopted co-testing, and most of the countries are planning to switch from Pap smear to HPV as a primary modality of screening. So let us see. So WHO in 2021, July, it has recommended that HPV is the preferred method for cervical cancer versus Pap via or Pap smear. So the starting age is 30 and every 5 to 10 years, we have to repeat it. So it is also more cost effective. So we can go either for screen and treat or screen, triage and treat. It is more simpler, more objective. It is more reproducible also and prevents more pre-cancer and cancer, and mortality is also reduced. It saves lives more compared to via or cytology according to various research papers which I found. Coming to the various lacunas and loopholes of the Pap smear, like these are also combated with HPV, like the inter-observer, intra-observer differences which were observed with cytology, they are not present with the HPV. Likewise, inadequate samples leading to wrong results, technical errors, high false negative results, they can be overcome by HPV. HPV test is also technically easy. And HPV test say we can decide whether the patient needs immediate colposcopy or should return to routine follow-up in every 5 to 5 years. So because if HPV is positive, then the next thing is we can go for colposcopy, triage. So it is found that if HPV is delayed even for a month, then the chance to stop 48 extra women from developing cervical cancer will be missed. Likewise, if we delay the implementation of HPV screening by 1 year, it would lead to a loss of 1,595 quality-adjusted life years of women. So such is the magnitude of importance of HPV testing. In various studies, it was found that the number of women who were referred for colposcopy is also very less as compared to referrals when they were solely based on Pap smear. इंडिया में तो कॉल्पोस्कोपी थोड़ी सस्ती है, लेकिन फॉरेन में इट्स अ बिग इकोनॉमिक बर्डन टू द पेशेंट बिकॉज दे से दैट कि इससे ज्यादा एक्सपर्टाइज की रिक्वायरमेंट है, इंफ्रास्ट्रक्चर की रिक्वायरमेंट है. और इंडिया में इंडिया इज आल्सो इट्स क्वाइट डिफिकल्ट फॉर द पेशेंट्स. वी हैव टू उनको मनाना बड़ा मुश्किल है. WHO has said HPV DNA, but in the second phase of WHO 2021 guidelines, they have said that even HPV mRNA E6, E7 protein might also be done. This can also be detected, but the thing is, it should be done at an interval of 5 years, and it can be done with or without triage. And it can also be used as a primary screening test, but the guidelines are more in favor of, at present, HPV DNA as compared to HPV mRNA. In general population, HPV DNA is the primary recommended test. Similarly, in people living with HIV, also HPV DNA is the primary recommended test according to WHO guidelines 2021 in low resource and middle income countries. So in the screen, how to manage these cases in the screen and treat approach according to WHO, the decision is based on positive primary screening test. So positive if HPV is positive. So if the woman is screen negative, that is HPV is negative, that means the woman does not have CIN or cervical cancer, and there is chance that highly likely that she will not develop cancer in the next 5 to 10 years. It is a very high negative predictive value. So negative HPV test is very reassuring, and we can extend the screening interval to 5 to 10 years. So repeat screening can be extended once we have a negative HPV test, it's a great peace of mind. If at follow-up visit indicates HPV test positive, then we need to investigate further by means of colposcopy. If HPV is negative, then regular screening. And according to WHO 2021, stop screening at age 50 years after 2 consecutive negative results. This is applicable for both the general population as well as people living with HIV, because in people living with HIV, there are more chances of getting cervical cancer. But WHO has also said that if HPV testing is not operational, then we need to go for 3 yearly Pap smear or VIA. So for HPV, screening even twice in lifetime is beneficial. We can reduce the screening duration also. For HIV, HPV DNA is the preferred modality. As I already said that HPV mRNA is not preferred. In HPV, for normal population, we can go only for screen and treat. Screen में positive है तो treat कर दिया, CIN 1-2 है तो जो भी है ablative procedure या cryo. But here screening, triage and treat. And for HIV, the age is 5 years earlier, that is 25 years, and the duration of screening is also 3 to 5 years according to the WHO guidelines. That is, the screening interval is reduced, the age of starting is also reduced. So, what are the benefits of HPV as a primary screen? So, we know it is more sensitive, it is more specific, it is reassuring. Negative means negative. Fewer examinations are there. False negatives are minimized. The focus is at risk. And it predicts the outcome and mortality and extends the screening interval. Moreover, the participation of women is increased, coverage is increased, and screen only women between 30 to 60 years of age. Early screening is not indicated because 21 years se jo tha, usse incidence of CA cervix was not increasing. So HPV co-testing increase the detection of CIN2 compared with cytology alone. So co-testing is also a good option. HPV testing is more accurate than repeat cytology at triaging patients with ASCUS following cytological screening. So after Pap smear, if we get a patient with ASCUS, so instead of going for repeat cytology, it's better to go for HPV testing then, because it's more accurate. And HPV produced higher pooled sensitivity with similar specificity. It's a useful tool in decision making. So these are the guidelines which Madam has already discussed. These are the latest American Cancer Society guidelines of 1920. So let us revise them. To 21 to 24 years, there is no need of screening. 25 years के बाद preferred है कि आप HPV testing कीजिए, और acceptable है अगर HPV testing नहीं है तो आप HPV और co-testing कीजिए with Pap smear, और अगर वो भी नहीं है तो आप अगर सिर्फ Pap smear कर रहे हैं तो 3 years में Pap smear कीजिए. 30 to 60 years preferred is HPV testing every 5 years. Screening interval बढ़ गया है, और co-testing is also good. It is also acceptable. But if it is HPV co-testing is not available, then go for Pap smear every 3 years. And 65 years के बाद अगर पुरानी सब negative है, तो there is no need of screening. This is the US Preventive Services Task Force, and these are previous American Society of this 2012 guidelines. तो पहले तो Pap smear ही था every 3 years. So this is the same thing. So American Society guidelines से अभी difference क्या है कि but there is one hitch with some HPV this test. HPV has also a certain false negative value, and there are certain documented cancers which are HPV negative also. So by commercially available test, delayed diagnosis may be there. It could result in higher stage tumors due to longer 5-year screening interval after negative HPV results. So at any stage of life, patient का एक बार co-testing with cytology भी हो जाए, that is the American Cancer Society guidelines. So women should have a morphological examination of Pap smear at some point in the screening history, and should not be screened slowly with HPV test, especially for older women with an uncertain screening history. Now coming to self-sampling for HPV. In the COVID times, WHO has approved self-sampling of COVID, HPV. It will reduce the logistic burden for the patients and the healthcare system. Patients are more, privacy is maintained, autonomy is maintained, patient का daily routine workup नहीं maintain होता, cost effective भी है. So WHO recommended है कि self-collected vaginal sample is as good as physician-collected sample, and there are many studies which say that participation is increased when self-collected specimen was there, self-sampling was there, and even in various meta-analysis, that patient ki acceptability for Pap smear and cervical screening was increased by doubled after adopting self-screening. So how to do this self-screening? This is a very simple. But with the same self-screening sample as told by Minakshi madam also, we can also test for gonorrhea, chlamydia. So the thing with self-sampling is the sample should be adequate, it should be acceptable, and it should be acceptable to the population, and it should be accurate. So prerequisite. And it has been found in various studies that the sample adequate, it is acceptable to the population, and it's also self-sampling is equally sensitive and specific. So self-sampling can be done without any supervision at home or in private clinic, and it acceptable है क्योंकि traveling का time बढ़ जाएगा और pandemic corona में where healthcare visits are reduced. But the thing is, information should be there. Individuals must know how to take the sample, what should be done with the sample, and after sampling, अगर कोई problem आती है तो then they should need to visit for the follow-up care. And kit for sampling should be made available, and policy and regulatory framework should be followed. So HPV self-sampling can be used to increase the participation. So what we with the same sample we can same sample जो self-sampling का है, we can also go do liquid-based Pap smear also. So we just introduced into the vagina. We asked the patient to introduce into the vagina, and the swab of cervical cells is taken and specimen is sent. If it is positive for high-risk strains, then it's pre-cancerous. If it's benign, negative, then it's likely to be benign or regress. HPV self-testing जो है, it can be used for follow-up of screen-positive women also, because who require further investigation. Sensitivity is also equal as initial connected specimen. It's also time saving, acceptable. So, but there are certain considerations which we should consider before choosing HPV as the primary screening modality, because there are so many tests available. We have to choose an HPV test that has been clinically validated, which is US FDA approved or EMA approved. Because if we suppose if we introduce certain HPV test in India in a screening program and later we change it to another test, it's not logically possible, neither it's cost effective. And these HPV kits also have expiration dates like 9 months, 12 months, and supply chain management aspects need to be considered in the context of the screening program. So there are various HPV tests which are available. The most common which is used is PCR-based test, RT-PCR-based test, even TrueNAT test, which has been used for COVID testing. So TrueNAT test can also detect HPV testing. So most commonly, Aptima HPV assay and COBAS test, these are most commonly used, and they are very highly sensitive and specific. Only if the problem is the sample collection is there, then we might face some problems. Otherwise, these HPV tests are in themselves very sensitive and specific. All COBAS is FDA approved. COBAS इसमें robotics भी है, 24 hours में 13,000 samples it can test. Then there was another study. It's the biggest population-based study in China, where 11,60,000 women were triaged to two groups. One HPV positive women were triaged by cytology alone or cytology along with this thing. And they they found that with HPV, the detection rate of CIN2 was improved. But there is a challenge with HPV testing. Most HPV infections are transient. Therefore, triage testing of HPV positive women is recommended to prevent over-referral and over-treatment. There are other advantages of HPV testing. It has a higher and long-lasting negative predictive value. Duration is increased, so permitting an extension of screening interval to 5 years or more. Even once or two HPV screen in a lifetime may confer substantial preventive benefit. As already stated by Dr. Minakshi, just one or two screening is sufficient. It can be successfully implemented as a see and treat approach, where screening, triage, and treatment, that is by cryo, is provided in the same visit. So point of care HPV testing platforms are available, rapid results can be provided. And thing is, a limited skill of laboratory technician is required for this thing. And moreover, HPV testing is better for women who had HPV vaccine. And it leads to better detection of CIN lesions and used better for post-treatment surveillance. जिनका क्रायोथेरेपी हुआ है या प्लेटिव थेरेपी हुआ है तो पोस्ट ट्रीटमेंट सर्वेलेंस के लिए HPV टेस्टिंग बेटर है. CA सर्विक्स की मोर्टेलिटी कम हो जाती है, सर्वाइकल कैंसर का इंसिडेंस कम हो जाता है बिकॉज false negatives are less. But there are policymakers have to face certain challenges in implementing HPV as a primary modality. So they have to choose which HPV test, what is the triage method, how to follow up, how to refer, what is the age range we have to decide, what's the screening interval, what is the communication strategy, training strategy for healthcare providers. Before implementing HPV in India as a primary modality, the policymakers have to decide all these things. Infrastructure establishment should be there. And ensure, okay. What is these things also we have to see. Foxy GCPR recommends co-testing from age 30 to 65 years of age. So let us join hands together for cervical cancer elimination with a new approach. Cytology, HPV-based screening, opportunistic, always go for community-targeted screening, and physician or self-sample to achieve our 90-70-90 target. Thank you. Thank you so much, all the audience and Maninder madam.
Yeah, Dr. Indu.
Yeah, thank you, Dr. Ruchika, for such an elaborate and informative talk. It means that the HPV testing should be made a primary method of screening according to this. Then we are going to pick up more cases and the interval is also increased. That may be going to be cost effective also. So let's see what policymakers are going to do. So thank you so much for an informative talk.
May I add one sentence?
Yes, ma'am.
Sure.
Incidence of HPV infection in India is supposed to be 7%. So when we are doing primary screening by HPV, then in that case, we will have lesser need to do co-testing with Pap smear or LBC or VIA, because it will be more cost effective. When we are doing screening by HPV, we are starting at 30, we are doing it every 5 years or maybe 8 years or 10 years down the line. And since incidence in India is very less, 7% only, if only 7% we have to do co-testing by triaging, by LBC or by VIA, then in the long run, it is more cost effective than anything else. And definitely HPV is more sensitive and specific.
Yes.
So maybe in the long run, we'll be more saving by taking HPV as a primary screening tool.
I think, Dr. Mala, I agree with you that it is going to be more cost effective because I think years back when I was vice president, Foxy and cervical cancer screening was my agenda. And I had gone to a very prestigious organization at that time. They were just talking about cytology only. And when I said the future test is HPV DNA, they said, what you are talking about, how that is possible? It's not feasible, it's not cost effective. But the thing is that it is cost effective. And it is going to be the future test only. We should be, government has to reduce the cost of testing. That is what they should be doing. And another thing which they have to reduce is, I think, the cost of vaccination also. And I think, Ruchika, so far self-testing is not available in our country. Dr. Mala? Minakshi?
नहीं मैम, वो जो LBC के kits होते हैं, liquid based.
In some research settings, it is self-sampling is available.
But not otherwise for the public. It's so far it's not available.
मैम जो LBC के जो kit होते हैं, उसी से patient self sampling भी कर सकता है.
But all the labs taking them up for general public. So far, I think Dr. Mala, she's saying they are just available for the research.
The research setting, they are available, but not for the general public, because you have to educate the public about how to do it. For
general public, it is not available.
Yeah. And what are the tests which we are doing normally? That was the question in the question box. Which normally HPV DNA testing, which test we are doing? That you had highlighted COBAS, whichever is available.
Yes, COBAS is available. Yes.
Yeah. So these are the ones.
COBAS is also RT-PCR based test, PCR based test. Yes. PCR based tests are available in India.
They are sensitive more, but not that specific.
Specificity is 90% because it does not tell you whether this infection is active or it is transient or persistent or transient. That is why it is less sensitive. Otherwise, it is 90% sensitive. Yes. And specificity is definitely 96%.
इससे थोड़ा ये भी पता नहीं चलता है कि कौन से patients अभी next few days में या months में pre-cancer में जा सकते हैं.
Yeah, so it is less sensitive.
That is why finally we need the Karposcopy in all the cases. That is where we are learning into now.
No, ma'am. We don't need. If he is HPV, यही तो बात है कि अगर हमने HPV negative है तो we don't need anything for the next 5 to 10 years.
If it is negative, then it's okay for 5 years. If it is positive, then we have to go for the Colpscopy. That is the thing. That is the issue.
Thank you, Ruchika ma'am. Thank you so much. Now coming to the next talk, I would like to invite star of the evening, the organizer of this evening, Dr. Maninder ma'am, and chairperson, Dr. Anita Sabharwal ma'am, for her next talk, that is colposcopy from normal to abnormal. Dr. Anita Sabharwal ma'am is FOXY champion and chairperson Public Awareness Committee of ISCCP, Secretary Forum of Obstetric Gynecology of South Delhi, past chairperson Adolescent Health Committee of AOGD, executive member of AOGD, and she has organized many CMEs conferences. Good evening, ma'am. Please welcome Maninder ma'am for her talk.
Thank you, Dr. Gurpreet. Thank you so much for your kind introduction. And at the outset, I must thank this grand speaker of the day now, Dr. Maninder Ahuja, for giving me the opportunity to be part of such a great galaxy of people over here today. And the president of IMS Society, Dr. Ambuja, I was just wondering, I have known her and how I remember now when she was for the elections, she called me herself personally. So I was really finding that such great people are here. So no wonder Dr. Maninder Ahuja has all such great friends, And Dr. Maninder Ahuja ki introduction mein kya do? She's such a wonderful, beautiful human being, and at the same time, such a strong personality. She's, she's motivating so many and she's inspiring so many people. And she's such a grounded person. And सबको साथ लेके चलती हैं. I've been knowing her for the last more than 16 years. And I've been constantly following her, and learning also so much from her. I think nobody can be like her. So मैं वो word use करूँगी कुछ 2-4 लाइनें हिंदी की, because अब हमारा last topic है and I will steal 1 minute from this for her कि आंखों में मंजिलें थी, गिरते और संभलते रहे. आंखों में मंजिलें थी, गिरते और संभलते रहे, आंधियों में क्या दम था, चिराग हवाओं में भी जलते रहे. So that is our Dr. Maninder Ahuja. In spite of so many odds, whatever she has come across, she still keeps going up and up and motivates all of us, whether on Facebook, wherever. So thank you, Dr. Maninder Ahuja, for coming in our lives and brightening our lives. And Baki to everybody knows she is academically so strong. And she is at present, everybody knows, she has been having so many posts to her credit. She was in Foxy as vice president, president of IMS Society she has been, and I think author of so many books, so many publications, and
I
great
that I
clinician.
was introduced. Thank you very much.
Yes,
And,
yes.
thank you for the kind words. And anyone can judge Anita's personality, the way she has introduced me. She is a friend of friends, and she has become a leader in her own way, because everybody wants to do something, needs her help. So let's go to the topic where we have to do. The only thing is that I had this book, first week book, because when I became the vice president of Foxy, there was no reading material for pre-cancerous lesions of cervix. So with the help of Dr. Partha Basu, who is the pioneer in the cancer research now, and whose slides I'm using here today just to show you what the normal and abnormal lesions are there, was the one who co-authored with me in this book, and I was really honored. And then Dipanvita Banerjee, who is doing her now MCH in oncology from the All India Institute of Medical Sciences. And forward was by, of course, by Dr. Hema Divakar. So today I'll be just talking about cervical colposcopy normal, what we have to see, and what will be the abnormal lesions like, but management we'll be doing in our subsequent webinars, because that will be covering a lot of time. So just to make people understand why they are not doing it, it's a very, very easy procedure. So I'll make it very simple. Like everybody has talked, why cervical cancer is important, because of the sheer number of patients, 122,000 every year who are being cervical cancer, and 50% of them die. The same figures are all over world, 270,000 deaths from cervical cancer screening. And sad part is this is from a cancer which is preventable. Which has a long course of action. And this is, we know its cause, HPV virus is the cause, then we have the vaccine available. And then we have very easy screening modalities which are there, which are already our speakers, Dr. Minakshi and Dr. Ruchika Garg has highlighted, so easily available. And then even diagnostic procedures. After that, colposcopy is not difficult, which is there too. And the treatment modalities are just OPD procedures also. That is why, but still we are not being able to reduce the incidence. What is this thing? Because I think somewhere we are. So why, considering all these problems and the high amplitude, our previous speakers, Dr. Mala Srivastava, everybody has highlighted the WHO program of 90, 70 and 90, which the figure we have to keep in mind. So we have to manage these cervical cancer cases. I think that is very important. So if the screening, does the screening saves lives? No, screening does not save the life. So what saves the lives is the management of these screen positive lesions. So screen positive lesions, also screening for those lesions we have already discussed, that there is a single visit CN treat approach, or triaging we can do with HPV, cytology, via or Willi. Then after triaging, we have to do colposcopy. Then we have to select a case, whether she needs biopsy or she can be treated at the same sitting, and then follow up after treatment. So today we'll be just talking about why we are not able to reach to the last mile for the healthcare providers also, and with the patients also. Perhaps artificial intelligence might just be the key to revolutionizing the way millions of women are being diagnosed and treated, and for prevention of diseases also. And I think for that, even for the cervical cancer screening, we need that cytology, artificial intelligence. As Abraham Lincoln very nicely said, give me 6 hours to chop down a tree and I'll spend the first 4 sharpening the eggs. So what is our eggs here in cervical cancer screening? What are our challenges which we are not able to meet? So challenges are large population, so how to reach out to them. So that means our last effort will be colposcopy in treating those lesions which have come positive because of that. So perhaps we need better colposcope. We have lack of trained persons. So we need colposcopes which can do the training along with the visualization also. Variable screening methods are done. Follow-up after the screening has to be done. And again, their colposcopy is useful. Follow-up after treatments is required. And again, colposcopy is required. Slides are not moving. Yeah. So what we had in 1920, these were the huge colposcope, binocular colposcope, where we cannot move them and which are very uncomfortable. They are time consuming also and a strain for the physicians also. So now what a colposcope is basically a microscope which a magnification of 6 to 40 is there, and it gets illuminated view of not only cervix. Remember that we have to see, we can see the vagina, vulva and anus also. And as was highlighted by Minakshi, that human papilloma virus causes lesions on these parts also. So when we are doing the cervical colposcopy, we should examine these areas also. That is very important. And focal distance is 25 to 30 centimeters. So when we are focusing, we should be looking at the cervix is at, it should be at this distance from the colposcope. So now selection of colposcope is very important, and portable micro colposcopes have come of different types of pocket, binocular, mobile are also there. So what these have, they have the zoom in facility, zoom out facility, display, even green filter light is there. And so you can still the image, take the images, and they come on a screen, very easy to look at. Then other advantages of these are that you can do, yes, upright eye level positioning, electronic medical records can be kept. You can consult other persons, even paramedical staff can do. Images can be compared with other images also. They can be sent for second opinion also, and treatment can be decided at a third center also, which are already connected to these by artificial intelligence. Or so these are the shorter examinations, and they offer a compact mobile solution to reach out to the last mile of them. So we have to change to our colposcope, because then we will be getting these images to look at the same time. All the digital colposcopes now have these facilities, and reporting is also there, and keeping the images and storing is also there. So that way we will be getting more and more data on cervical cancer screening, and artificial intelligence is going to play a big role in cancer screening. And in many countries, especially now, these are being utilized by the paramedical staff, and then the other qualified personnel can make the treatment, the patients can be referred there. So that is how the huge load of patients which is with us can be reduced, and we can take help of the technology. Now, my two speakers have made my job easier, how to do the trials. Now, the GCPR guidelines and other people, WHO guidelines also say the same thing, that depending upon your facility available, you can do whether it's good resource setting or limited resource setting. So you can do via or HPV DNA, or you can do HPV DNA as a primary modality. You can do HPV DNA as a co-testing. So whatever methods you do, you triage them. And if the patient is positive, where you can, the lesion is so that you can treat it with the cryoablation, or with the thermoablation, or you have to do what the leads, or you can decide and do at the same visit. If you have the Karposcopic center, if you don't have, then you can refer these patients. But whatever facility is available, we should be using them. So it's very easy to do these things. If you just don't have anything, VIA and VILI can be done by all the gynecologists, and it does not take much time even. And then they can be referred. We can have a shared practice, or everybody can go in for these colposcopes also and invest money in that. So indications for colposcopy: screen test positive HPV via VILI. If it's only thing is, if it's HPV negative, then high risk negative, then you have to do it, repeat it after 5 years. Otherwise, abnormal Pap Smear Cytology, if it's SCS or below, then you can wait for 6 months or repeat after 6 months or 1 year. But discrepancy in screening reports is there, then you have to refer them for colposcopy. And colpo-guided biopsy wherever needed. Treatment of Cn lesions, again, you need colposcopy. And for follow-up of these cases, you need the colposcopy. Now, you have triaged a patient and you are going to take that patient for colposcopy. So simple thing, what you need then? You need simple swabs are there, sponge holding process where you have to clean the cervix so that you can look at it properly. But never do it with the dry swab, always do it with saline. So you have to have a saline, you have to have acetic acid, and you have to have Lugol's iodine. Some people use Mansell's paste for bleeding if there, I never use it. But you need self-retaining speculum, cusco bivalvular, and they can be insulated speculum, especially if you have to use the electrocautery. Then different types of these electrodes are available where you have to do leads. So if you are doing it and yours is a colposcopic center where you are expecting the patient to be lesion positive, then you should have all these things ready. Along with that, what you need is the Reichler cervical biopsy forceps, because if you have to take a biopsy, it should be available. And then Cogan's endocervical forceps. These are very, very useful, especially in the type 2 transformation zone, where we'll be talking about type 2 or type 3 transformation zone is there. So you need this light source, insulated speculum, smoke evacuator is very, very helping. So my advice to all of you is, if you are going to start with colposcopy, as this is just your pipeline attached to your speculum here, there in this there's not. So there's a smoke evacuator and you attach it to your normal suction tubing, and the electrocautery machine has to be there. So colposcopic examination involves what now? After normal saline application, you look at the cervix, then apply acetic acid, then Lugol's iodine. As we go along, I'll be explaining those methods. Then general assessment, educate colposcopy or not, squamocolumnar junction, visibility, and transformation zone, which is type 1, 2, or 3. Then it's normal colposcopic finding, because you have to document all these things. Documentation of these is very, very important with the colposcopic centers. Then abnormal colposcopic findings will be looking at. And then suspicious invasion and miscellaneous lesions, which can be there. Sweet score, provisional diagnosis, and management plan. So that is what we are going to look at today. Management we won't be doing today. We'll be doing in the subsequent webinars. We'll be just looking at the normal cervix and abnormal findings and abnormal lesions. So what the first step is, we apply acetic acid. So why we apply acetic acid? Because it dissolves the mucus and it causes coagulation of proteins, induces intracellular dehydration. So what becomes? As a result, cells with increased nuclear cytoplasmic ratio will become white. They will take up the acetic acid. And those who have a more nuclear density or chromosomal aneuploidy is there, they are going to become opaque. So that is the purpose of applying acetic acid. Then you can locate the squamocolumnar junction, identify lesion, its limit, decide whether the lesion is low grade or high grade, identify if invasion is present, and select appropriate site for biopsy. So when you are doing colposcopy, you are going to do all these things. But the first thing is that you should look at the cervix. And cervix, should be looking at you, not you looking at you, cervix, but cervix is looking at you completely. So that means you can visualize the cervix completely. So squamocolumnar junction, that can be identified. Now, if the vaginal walls are coming in between and you cannot see, and you can do the COT even later on, so you can apply a condom. So you have on the speculum itself, you can have a condom, so that will give you better visibility. So colposcopic examination of the normal cervix is, you are going to look at the squamous epithelium, which is pink and smooth. Then you are going to look at the columnar epithelium, which is red and granular. Then you are going to metaplastic epithelium, both mature and immature. So this is how you are going to look at an transformation zone, which is, this is the transformation zone. You are going to identify it with the Nabatean follicles and with the opening of the glands. So this is the ectropion, which is the columnar epithelium, which you can see. Then the squamocolumnar junction, new, squamocolumnar junction, old, and transformation zone in between is the transformation zone, which is recognized by the Nabatean follicles and by the further crypt openings. So this is what you have to, if it's a adequate colposcopy, then you should be able to see cervix, and it should not be obscured by the mucus or inflammation or pus or blood or septum or old scars and or any discharge. And transformation zone should be seen completely. Now, what is transformation zone is that the columnar epithelium of the endocervical canal meets the squamous epithelium of the ectocervix. All of us know at birth, and when the patient undergo puberty, then this columnar epithelium grows outside, and under the effect of acidic environment, oxygen, it gets changed into squamous epithelium, and in between there is that metaplastic changes which are occurring in that cervix. So when you can see it completely, that is transformation zone 1. When you cannot see it, it is going inside the endocervical canal, but you can see the upper edge, then it is transformation zone 2. And when you cannot see it at all, that is transformation zone 3 type, that is like in atrophic changes which are occurring in the menopause. So previous speakers has highlighted that in menopause, we cannot use via-villi as a testing. So this is the transformation zone 1 and transformation zone 2 and transformation zone 3, where we cannot see the upper edge. So that is what you are looking at. So again, I'll be showing you many images so that you can get familiar with the normal epithelium, normal columnar epithelium, metaplastic changes, and the atrophic epithelium is there. So this is the metaplastic changes which are occurring, where what is occurring is that columnar epithelium changes from the basal cells into they start dividing, and because they don't have glycogen, so they don't take up the color of the Lugol's iodide, which is black in the normal squamous epithelium. So that is what then it can take a faint white with the acetic acid, and the irregular edges will be there, like geographical edges. So these are the cells which are taking up the subcolumnar reserve cells, which convert the columnar epithelium into squamous epithelium. Until the fourth stage, these you can see images, they don't have glycogen, presence of glycogen. That is why they cannot take the Lugol's iodine. But abnormal cells will also not take the Lugol's iodine. So patchy squamous epithelium in the transformation zone will be there when the cervical metaplasia is there. So thin, aceto-white, transparent, grayish, and Lugol's iodine patchy uptake will be there. These are the ectropion or ectopy, and this is not erosion, because erosion is something different where the epithelium is being peeled off. Difficult situation, pregnancy, glandular disease, and congenital malformation. Congenital transformation zone. Congenital transformation zone is not actually a lesion, but it's an intrauterine squamous metaplasia which is not completed. So it's seen can extend up to the fornices even, and thin white opaque layer will be there. But this is a normal finding which will be correcting itself later on. During pregnancy, we can find these small elevated vascular nodules and sessile polyps which can look like the abnormal lesions, and then we might have to take a biopsy from them. The case also demonstrates that the importance of examination by speculum to look for local causes of bleeding in cases of abortion and antepartum hemorrhage. Whenever we are having these cases, we should look at the cervix also. So whenever you find a lesion on the vulva, you must always look at the cervix. That is another principle should be there. Then there will be infections which will be seen on colposcopy, and you can make them out. Candida, by curdy white cheesy discharge, Trichomonas vaginalis, yellowish foul smelling discharge, bacterial vaginosis, also red inflamed cervix. And this is the leopard skin like typical appearance on the Lugol's iodine is there. Now inflamed cervix will be looking as red and beefy, and this might take a little bit of acetic acid also, and this can be because of chlamydia or gonococcal. Then inflamed cervix with different patches, erosion can also be there, and sometimes prominent blood vessels will be there, but then they will be tapering of cervixes will be there, and patchy uptake by Lugol's iodine inflamed cervix can take up. So what is the erosion? Erosion appears as any red patch on the cervix. Ectropion is always surrounded by the external os, but this can be if it is on an inflamed cervix, if you are just rubbing it off, it will be peeled off that skin. But if it is in a high-grade precancerous lesion, then it will be at the background of a white, astro-white lesion. So then you can see these rags or peeled off edges can be there. And with inflammation, whenever we are debriding, but there that thick white, opaque white lesions won't be there. Post-menopausal atrophic lesion, again, you can see because this epithelium is very thin, so it can be peeled off. Then other lesions which you can see is endocervical polyp, ectocervical polyp, congenital abnormalities, and rarely you can see the, endometriosis also. So this is the endometriotic lesion which you can sometimes see with the colposcopy. So non-specific findings like leukoplakia can be there. Leukoplakia can be there even beyond the squamocolumnar junction also. But if it is with the our transformation zone, then the biopsy should be taken because underlying malignant lesion can be there. So we have already seen these inflamed cervices, leukoplakia, patchy take up by the Lugol's iodine. Then post-treatment services. These are the post-lease services, again, where we'll be looking that healed is there. Sometimes you find after 6 or 8 weeks, absolutely healed cervix is there and complete squamous healthy epithelium is there. Or you can see that there is a patchy take-up by the Lugol's iodine is there. And healing and regenerating epithelium sequel can be looking like this. In squamous metaplasia, sometimes you can have the islands of columnar epithelium also, which will be seen. So whenever now colposcopic finding, when you have seen, you have to do documentation. So documentation, first part is very, very important, that where the lesion is seen. So you divide into 4 quadrants, and you can say how many quadrants the lesion is occupying, or you can say it's a 12 o'clock, it's a 3 o'clock, it's a 6 o'clock, it's a 9 o'clock position. Then you have to use various sweet score, which can be used that I'll be talking about, and then you can make the provisional diagnosis. So I repeat again, when you are looking at the colposcopy, whether it should see whether it's adequate or inadequate. Secondly, squamocolumnar junction is visible, complete, partial or not. Transformation zone is seen or not. Then normal colposcopic forming, you have to see at the original squamous epithelium, columnar epithelium, transformation zone 1, 2, or 3, and deciduosis in pregnancy, atrophic epithelium, Nabothian cyst, gland opening. So you have to report all these things. Then we will come to the abnormal epithelium now, grade 1 or grade 2. That will depend upon when we apply acetic acid. We look at the margins, we look at the opaqueness, and then we can look at the Lugol's iodine uptake and the blood vessels. And then suspicion of the invasion, will be looking at those slides now. So this is how the sweet score will be there, where depending upon acid uptake, we give the score of 0 or shady, milky, not transparent, then 1 or 2 distinct opaque white. So this is how we are doing the scoring. Margins diffuse, sharp but irregular, sharp and even differences, and raised surfaces, then 2, then vessels fine and regular, 0, because in the normal cervix, you can look at the vessels which will be there on the Nabothian follicles also, and at the margins of the transformation zone, but they are always tapering and thin. And sometimes when you apply acetic acid, they constrict. So before applying acetic acid, please apply the green filter. And after applying the acetic acid, when it fades away, again, you can apply the green filter. So you see the margin, then vessels, absent, coarse or atypical. I'll be showing you images again. Lesion side, whether it is less than 5 mm, 5 to 15 mm or more than 15 mm, then that way scoring is done. And iodine scoring is very important, but iodine scoring has been done on that area where the aceto acid was white. So there the lesion will be there. So we will be have to show whether it's a brown, that is because of the glycogen content, which is the healthy, faintly or patchy, where it's appearing, becoming replaced by the squamous epithelium, and distinct yellow, mustard yellow color is there. So total scale 0 to 4 is normal, CN1, 5 to 6 is CN2, and total score is 7 to 10, then CN3 or high grade lesion is there. So in those cases, then we have to take a biopsy or see and treat approach at the same time. Details we'll be talking about in the second webinar. So this is how the leukoplakial lesions are there outside transformation zone. If they are in the transformation zone, then take a biopsy, and this is the Lugol's uptake by them. This is how we are going to see the size of the lesion and tell them how the lesion is being seen. Grade 1, thin, aceto-white lesions are there. No uptake by the Lugol's iodine there. Then fine mosaics are there. That is in the low grade lesions or fine punctations are there, CN1. And if they are high grade or suspicious lesions, then let's look at what they are like. So again, the same, you have to see the findings, aceto-white, fine mosaic punctations, coarse mosaic punctation is major, coarse sharp borders, inner border sign, ridge sign is there. So let's look into those images now. This is rapid appearance of aceto-white lesion, that is more in favor of major lesions is there. Thick white opaque lesions are there. Then coarse punctation and coarse mosaic, ridge sign, cuffed gland openings, cuffed crypts openings are there. So I'll show you these. These all will tell you that they are high grade lesions. So this is coarse punctation now. Coarse punctation and coarse mosaic. This is the coarse mosaic. This is the coarse punctations. These are the rimmed glands. It's getting forward. So these are the rimmed glands, and this is the inner border sign, where because of the being hypertrophy of the epithelium, it's raised above like a ridge. This is sign. Squamocolumnar junction. It's near the squamocolumnar junction, and it projects like a wall or ridge. And inner border sign is when there is a low grade thin aceto-white area, and on top of that there is thick inner border, thick aceto-white area, opaque. that is the inner border sign. So abnormal blood vessels, these are the normal blood vessels, non-malignant, where red dotted lines, thin spots are seen, or branching blood vessels, linear blood vessels, or loop-like. These are the normal blood vessels which will be seen. Abnormal blood vessels will be corkscrew-like, or thick coarse mosaic is there, or coarse punctations are there, or tendril-like blood vessels are there, waist thread-like vessels are there, willow branch-like vessels are there. Now, why these vessels are there? Because of the abnormal vascularization which is taking place. They are thick and they are abruptly ending. They are not thinning out. So that is the root-like characters. So let's see now these. These are the waist thread, tendril-like blood vessels. You can see them exactly looking like tendril. And these are the root characters blood vessels, root character blood vessels, which are thick and which are not tapering off. So these are the abnormal blood vessels. Then fragile blood vessels. Signs of invasion now, what are they? Fragile blood vessels which bleed on touch, irregular surface of the growth is there, exophytic lesion, necrotic lesion is there, and tumor gross lesion is there. So these will show that already the invasion has taken place. Now, whenever these abnormal lesions are there, if we find it's not that invasion is not there, then we can take a biopsy, or if we find it right, we can do the leads procedure at the same time. It is feasible. It's done outside OPD procedure only. My patients are sometimes very sensitive, so I do them under anesthesia. But most of the times, if we just give local anesthesia, we can do the OPD procedure. In our next webinar, we'll be taking the videos of all these procedures so that the things can be clarified. So whenever the lesion is there on vulva, you have to do colposcopy, because lesions might be at the same time vulval and the cervical cancers will be there, and biopsy should be taken from the vulva also and from the colposcopy lesion also. We always have to take a histopathology view of these lesions, because sometimes the whatever we see on the cytology may not correlate with the biopsy later on. So it's whenever in doubt, please take a biopsy and take it from multiple places. Biopsy is very easy. That punch biopsy, which I showed you, is very, very effective and very easy to do in your OPD procedures only. So this is the lesion where you take that there is just faint aceto-white lesion, aceto-white uptake is there. Then margins are irregular, 0. Vessels are fine and regular. I can hardly see, but here you can see the vessels. Lesion size is less than 5 mm is there, but iodine staining is there in this portion, so you make it as 2. So total score is 4. So this patient, but still at 4, I'll take a biopsy from this area. So whenever in doubt, take a biopsy. I'm going to take a biopsy from this area. This is another lesion where is distinct opaque, 2 sharp, even regular margins are there. Coarse atypical blood vessels are there. You can see these, and more than 3/4 quadrants are applied, being affected, and distinct yellow coloring is there. So this is 10. So this calls for a biopsy, and if the lesion is deep enough, then we have to, depending upon her requirement, leads can be done or conization has to be done. So that we'll be taking in details in our next webinar, because the time constraint is there. So this is 2011. I have CPC nomenclature is there, which I have highlighted at every stage. And again, I'm going to repeat: general assessment, adequate, inadequate, squamocolumnar junction. Its cervix is not being obscured by any discharge, pus, blood, or abnormality. And then you look at the squamous epithelium, mature, immature, or metaplasia is there, columnar epithelium. metaplastic squamous epithelium, nephrothene cyst and gland opening, then abnormal colposcopic finding depending upon acetovite uptake, whether it's faint, grayish or not, and then you have to do the Lugol's iodine again, then other pathology which can be seen. We have discussed that infections can be seen, leukoplakia can be seen, endometriosis and polyps, etc. They can all be seen. Then look at the vessels and miscellaneous findings, condylomata, polyp, everything we have mentioned. So all these you have to do the documentation in this way, whether it's available. My acknowledgement to Dr. Partha Basu, because they are doing wonderful work, and most of the teaching material you can find there. Slides are also there. So on this website, and thank you very much for patient hearing. Any questions are welcome, and please be there in our future webinar series also. Thank you very much.
Thank you, Dr. Maninder, for the wonderful, excellent presentation. And you really made it so much pictorial, as you said, that it was really a treat to the eyes. And one could really easily understand. I think people from all walks in the field of obs-gynae, from the primary level to the tertiary level, people like me also, you know, who are basically working at a ground level, we all could really understand. I must tell you, you know, I learned colposcopy in year 2000 from Dr. S.K. Das. That time she used to keep workshops, and we all she used to make us also be part of it. So that was the time, as you said, the machines were really very bulky, and we all used to, you know, in a line go and try to see, you know, how we could manage. So you really made it very clear, and all the steps were so clear, right? From the, you know, steps of how to examine till the documentation part, which is so important. So really, it was a great treat. And I think we have such great people here, the other speakers like Dr. Minakshi and our Dr. Ruchika. We keep hearing all of them. They are such great speakers. So all three of you have really done a wonderful job. Thank you so much. And Dr. Mala is always there to add to the whole show. And so thank you so much, Dr. Maninder, ma'am. Please
keep
on doing this.
Thank you, Maninder, ma'am.
Dr. Mala, your inputs, please.
Yeah. Dr. Maninder, that was really very exhaustive and informative session on colposcopy. You really highlighted what is the basics of colposcopy, what are the indications, how to do it, and what do you mean by normal colposcopy, and how do you gradually go towards the abnormal colposcopy. It was a really great treat, and as Dr. Anita highlighted, it was a real crystal clear pictorial lecture from the stalwart like Dr. Maninder Ahuja. See, basically, we all have to join hands to bring an end to cervical cancer. Cervical cancer is really a preventable condition by primary prevention, secondary prevention, and by tertiary prevention. 90-70-90 is the slogan of WHO as well as FOXI. We want to make India cervical cancer mukt. And everybody, each and every gynecologist has to put in an effort to achieve this and give the benefit to all our patients. Really, I congratulate Dr. Maninder Ahuja and Dr. Minakshi Ahuja, who has taken up this topic on this particular topic on this Cervical Cancer Awareness Month. And I'm sure all the delegates must have really benefited from the basics to the colposcopy of cervical screening as well as the treatment and the management. It was really a fruitful evening with great learning, madam. We all have benefited from this scientific webinars.
Thank you, Dr. Mala Srivastava, Anita Sabharwal, Minakshi, everybody. There are some questions in the chat box. Can anybody take it? Cost of HPV testing and which labs? Lal labs are doing, Renbexi are also doing, and then Metropolis are also doing. So costs, I think, vary for the, if you have to do HPV DNA as a primary modality, then it again varies from 1,500 to 2,000, depending upon what discount they are ready to give you. So that is the one thing. Self-sampling still not available for the public, I think. And tests are 18, 16 and 18 are the major contributors which we should be getting done. We are doing HPV DNA, and so far mRNA, though available, and many labs are doing, can be done in high-risk patients where they can afford also. So the main question in our country comes of affordability. So that's what I started doing, was viability and Karposcopy. So I have got a Colpscopy which is always available there, so that whenever you do a per speculum examination and I find it and the patient is ready to get it done, then I do at the same sitting Colposcopy also. And I think that is the way forward, where we should have dedicated colposcopic centers. If everybody is not able to do, at least do HPV DNA as a primary modality, or you can do viability, or you can do cytology with the HPV DNA as a co-testing. Whatever way you are comfortable, but please do it in one way or the other.
Also, we must, I think at the same time, do a lot of awareness campaigns, whether in the form of, even now we can do public forums. Only yesterday we had done one, and it was really wonderful because so many people participated. Like, we involved Jamia Hamdard University, so all the staff members, their families, so that we could aware them. And they had such questions, like so many people are still not aware of it, even at the teaching level, even the teachers, school teachers. So I think if we add to that, because with these kind of lectures, and then at the same time, maybe 2 forums for each one lecture like this. This is
Agree,
my
Anita, you are absolutely right. And next public awareness forum I'm going to do with you only.
Yes, sure.
I'm always there. Do lots of them.
Yes.
Actually, in IMS also we have public awareness program, but the problem here is when we are going to the villages, we are doing camps, we are just doing either cytology or viability. No one is diagnosing them and sending them for colposcopy at all. That is my main problem. I'm going to the health center now. I ask them, नहीं हम लोग कर रहे हैं, हमें उन्होंने सिखाया हुआ है. उसके बाद nobody knows. अगर कोई पॉजिटिव आ गया, एस्कस भी आ गया, एस्कस से ऊपर तो पक्का हिस्टेक्टमी का ये एडवाइस करना, आपको तो कैंसर हो जाएगा. अरे भैया नहीं होगा कैंसर. पहले तो it's a long history, and most of the times it's going to reverse back to the normal. That is why in younger patients we have to give at least 2 years, like they say. If it clears in 2 years, it's okay. If it's progressive, then only we have to treat them. Otherwise, below 30 years, we don't have to treat them at all, unless they are progressive beyond 2 years. So that is the message, I think, even to our own gynecologists, we have to go on talking again and again and again. So I think we should say, Gurpreet.
Yes, ma'am. I have an idea, ma'am, for this, all these HPV testings and screening. We can make small, easy readable slides that patients can understand, and we can put our status. Doctors can put that in status. Patients, they are, I understand doctors, we don't check status every day, but patients will definitely check your, status.
It's a good thing.
If you use the WhatsApp media and Facebook media for the awareness of cancer screening, it will give more benefit than to do a camp, than to do a free camp. We can mention the costing of HPV vaccines. We can mention the costing of colposcopy. We can mention the costing of HPV vaccination. That will give so much help to spread awareness.
Yes, that is
Also,
electronic.
one more point I'd like to make, Dr. Maninder, that I think it's very important to educate the other doctors of other specialties.
Absolutely.
Because this is a 30-year-old disease. But abhi tak people think that, what we used to read as undergraduates, that cervical cancer is there in prostitutes and not in nuns.
Even our ophthalmology
that it means that there is promiscuous sexual activity going on. So I think, educating our other specialties, our GPs, that they should see to it that every woman gets her screening done, gets her vaccination done. It is so sad that even after, more than 12 years of the vaccine being in there,
There are a lot of general physicians also, or ophthalmologists or other specialties who will say, nahi, kya karwani hai, vaccine, let it be. So that awareness among other specialties is also very important.
You are right, absolutely right, Minakshi. We have, that's why I say, that's why I've taken it up from the platform SMLM, that more and more work is required. Jitna hum log karenge, utna every time you at least will educate 1, 2, 10, 12. That will be, I think, more than sufficient if we go on continuously making our efforts. We'll be making India cancer-free Bharat. 90, 70, 90, 30 तक ये ना हुआ तो कम से कम 45, 50 तो कर दे. Which percentage so we should increase at least to make efforts, and all the organizations should come forward doing this thing. I believe strongly in that. So in that efforts, SMLM will be continuing its efforts. And again, I am telling you people, I am doing that project on correlation of menopause to metabolic syndrome. Please get ready. If you have not get yourself tested for your lipid profile, your blood sugar, your waist circumference, height, weight, BMI. You have to get it done. And please put the data. Don't be scared, because we are not going to disclose anybody's name. Name column is also not there. It's just
let us have Indian data. That is Maninder madam's vision, that we don't have, we are relying only on Western data. We Indians have different phenotype, genotype, everything. So let us help. Personally, you will have to motivate. एक WhatsApp group में 250 लोग होते हैं. आप डाल दोगे तो, but nobody is going to fill. Please ask your friends personally to fill the menopause and metabolic data. So even one of our member asked 10 or 20 of their members, then it will be, you can post in your family groups. तो सब लोग इस बहाने अपना metabolic profile, waist circumference measure कर लेंगे. Sugar and lipid profile, we can get it done. Even we don't know कि हम ही आते हैं कि नहीं metabolic syndrome की category में.
At least
last year we conducted a study. डॉक्टर्स के बीच में ही मैम हमने एक फॉर्म भरा था, गूगल फॉर्म, और ये वर्ल्ड हार्ट डे वाले दिन हमने उनको बोला था. तो दैट वाज वन ऑफ द एक्टिविटी ऑफ रायपुर मेनोपॉज सोसाइटी. तो सबने अपने अपने गूगल फॉर्म जाके भर दिए थे, एंड देन वी took out the data from there. That was 2 years back.
Who is this speaking? I couldn't see.
Dr.
But
Gurpreet.
unless we have personal motivation for the people. Yes, unless we have personal motivation, people will not fill, because these needs, आपको sugar करानी पड़ेगी, fasting करानी पड़ेगी.
Fasting, main is fasting.
But we
People
need
usually they don't go to hospital.
I would like to add one more point.
The lab people to our homes now. It's not difficult. They come running to your place, and they will just take 50 or 100 rupees extra for taking your blood samples. So it's not difficult at all. The only thing is we have to get South Asian countries data. That is very important, because our phenotypes are almost the same, but our studies are not there. Only we are using data extrapolated from other studies which have been done in UK or USA. Dr. Mala Shrivastava, you agree on that point?
Definitely, definitely. We have to have our own Indian data.
Yeah,
and we all will participate.
It's not difficult now, and to do
not at all.
Google form, I think it does not need ethical clearance because everybody is giving their own consent now, and it is done as a responsibility of medical healthcare persons for their own health, which is the minimum they should be doing for themselves. So I think on that note, I thank you everybody who is there, Dr. Mala, Dr. Ambuja, she has left her there, Dr. Minakshi, Dr. Ruchika, Dr. Anita Sabarwal, and Sonal, and Indu Taneja, and above all, Deepika Chabra. Deepika, you will be always there for us. Thank you very much. And all of you, thank you very much for being with us here on these platforms. That boosts my effort to go on working when I should be retiring, I think.
Thank you, Dr. Maninder.
And Dr. Maninder, you have to do more activities with IMS Delhi chapter, because your energy is infectious. We all want to be more part of more and more programs with you.
Yes, I'm going to be there with you for my public.
Definitely, definitely, Dr. Anita, such a pleasure.
And let's all vote for Dr. Mala Srivastava.
Sure,
We
sure.
need her.
Thanks.
For sure.
Definitely.
She's
We
very
are
old
old
Definitely.
people in Poxy.
Thank you,
From
ma'am.
Jagsonpal. From Jagsonpal also, we take this opportunity to thank everybody for being
Thank you
here
so
today.
much.
And,
Thank you, Jagsonpal Pharmaceuticals also.
and as you have seen, LycoRed, the cell protector, having chemopreventive properties. So those could be utilized for all your menopausal women and perimenopausal women. too.
Even cervical
Sure.
cancer patients, everybody
Yes.
can take the LycoRed. LycoRed is just
It's a very good
wonderful antioxidant.
Yes, no doubt.
Thank you.
Thank you so much. Thank you.
Okay,
Thank you,
good
Dr.
night.
Maninder.
We
Bye.
get almost to
All
the
right.
Bye.
Yeah,
Bye-bye.
bye.
Bye.
Thank you.
Good night and goodbye.
Good night.
Good night.